afternoon. Thank you for attending this month's OCHIN Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to welcome Dr. Shannon Sweeney of Oregon Health and Science University and Ann Romer of OCHIN as they present on better understanding practice facilitation efficacy. Dr. Shannon Sweeney is a senior research associate at Oregon Health and Science University, where she has worked for the past 4 years. Dr. Sweeney currently leads the qualitative data collection and analyses for several evaluations and studies, and she was the lead analyst and project manager for the qualitative team on Escalates, the mixed methods national evaluation of a $120 million federal initiative dedicated to using the latest evidence to improve heart health in the U.S. Dr. Sweeney's research interests include the social determinants of health and mixed methods evaluation, and she has been published in such places as, to name a few, American Journal of Medical Quality, Annals of Family Medicine, and Health Affairs. Ann Romer is the manager of the practice transformation team in the clinical operations department at OCHIN and oversees a team of practice coaches and medical home engagement specialists. Her expertise includes 5+ years at OCHIN as principal or supervising practice coach for health center adoption of team-based care processes and EHR integrated tools through tailored, scalable, virtual, and in-person support. Previous work includes serving as the Oregon Region Practice Facilitator for CMMI's CPC initiative, supporting a 67-clinic cohort to adopt CMS metrics for advanced primary care. In her current role as manager of the practice transformation team, Ms. Romer has led the team through over 24 multi-site, multi-year transformation projects with strategic focus on addressing clinician wellness and advancing equity. And she has been published in such journals as BMC Cancer and Journal of the American Medical Association, Open. This session is being recorded. Attendees are muted upon entry, so please pose your questions through the Q&A or chat box. This presentation will last approximately 45 minutes with 10 to 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Shannon Sweeney and Ann Romer for better understanding practice facilitation efficacy. Dr. Sweeney, Ms. Romer, the floor is yours.
Thank you so much, William, and I am delighted to be here. Let me make sure, are we seeing my screen?
Not yet.
Not yet? All right, let's see. I have not done this correctly, even though it was all set up. That's the first test, they say. Sorry about this, team. Let's see, back to Zoom. Share screen. Here we go. And there. All right. So as we discussed, thanks so much, William. I'm Shannon Sweeney, and I am excited to talk to you a little bit about a couple of studies that we've been doing using some Escalates data. So we're going to talk a little bit about better understanding practice facilitation efficacy and a little bit of background on practice facilitation. It's really a multi-faceted approach designed to improve the adoption of evidence-based guidelines. So this entails someone called a practice facilitator, as many of you may be aware, coming into a practice and making recommended changes and working with the practice to identify areas of improvement, set some goals, provide tools, and figure out ways for the practice to achieve these goals over a period of time. This is a common research strategy and is used in lots of different areas of research. And in several of the studies that we've been looking at in primary care, it's used for specific targeted outcomes. So the facilitator goes in and aims to improve certain measures. In the case of Escalates, these measures were cardiovascular in nature, but in the literature, we've seen that facilitators can really help increase a practice's ability to make and sustain change over time in a variety of areas. So diabetic care, smoking cessation, primary care offices, just getting evidence-based practices into their routine care, and really increasing practice's abilities to focus and make changes. Typically, support is provided on-site, although like everything in a virtual world, sometimes in a more recent virtual world, sometimes these things are done virtually or in a combination of modes. But in in all of these cases, we've seen that practice facilitation as an intervention strategy can be used to effectively make change in practices. However, most of the studies that look at practice facilitation and its efficacy are quite small in terms of the number of studies that practice facilitators are working in, and how we determine whether the facilitation is effective can be done in a number of ways. However, in the literature, most of the studies that are looking at efficacy are measuring this quantitatively. And so they're looking at seeing whether a facilitator who's in the practice can help the practice make a change in a measure from X period of time to Y period of time, and whether the measure goes up or down. And although this is an important way to see whether change is being made in practices, and when facilitation is successful, it often yields an increase or decrease in the measure as expected. It doesn't really get at the heart of the question, which is like, what does good facilitation really look like? What does an effective facilitator look like? What are the skills that they are using? What does it look like to be a practice who's receiving facilitation? Everyone wants to improve their measures, but what does it really look like when you see or know what a good facilitator is? And so one of the things we wanted to look at was, what does efficacy and facilitation really look like? And we wanted to do this through a mixed methods design, meaning that we have both our quantitative outcomes and then some qualitative data where we're able to talk to facilitators and talk to clinics and ask them about what they've done and their experiences. Our main research question was, what are the features of practice facilitation that contribute to facilitator effectiveness? We have two publications, one that's specifically focused on facilitator effectiveness that I'm going to focus on today, which is this one, Effective Facilitator Strategies, that was in Annals. And we had a previous publication that I'll loosely touch on at the end of the talk about the workforce that's required to support large practice or large scale practice improvement. And the reason that these two are both on this slide is because the support that is required for especially large facilitation networks is tied into, we have found, the effectiveness. So although one study is really targeted what we're talking about today, overall effectiveness, the previous study helped set up some of this work and looked at the types of support and the network of support that facilitators were getting to be successful. So Escalades was the setting for this study, which, as William mentioned in the introduction, was a very large ARC study funded with 7 cooperatives, so the 7 regions in 12 states. Over 1,500 practices were involved with 5,000 providers and 8 million patients. We had over 130 facilitators in this study among the 7 regions in the 12 states. And here are sort of geographically where the regions are. And so you can see as each of the regions come up, the practices that populate those regions and where the institution was, where the grant was sort of funded, and then the facilitator organizations were spread among these regions. So in the Pacific Northwest, you can see the practices were largely focused around the urban areas, but a few in Idaho. And so facilitators were from different organizations and would go to these practices and help them work on their outcomes. So we had this really large study. We have all of these facilitators. They're all working on these heart health measures, and we want to know whether they're effective. So we were able to use mixed methods, as I mentioned, and the way we were able to do that is we quantitatively sampled our facilitators. So we had a large number of facilitators, 142, and we looked to see whether they improved at least one outcome measure of the Escalade study, or the EvidenceNOW study looking at heart health. And those measures were aspirin, blood pressure, and smoking cessation, which help reduce cardiovascular disease. And so we looked to see whether for a facilitator's practices, whether they were able to improve at least one of those outcomes in 75% of their practices or more. That's what we identified as being a more effective facilitator. There was an additional measure that EvidenceNOW looked at, which was an adaptive reserve measure, which was a way that the practice, a measure that is from -28 to +28, and it's a way that the practice can look at sort of their ability to handle additional challenges in their practice, and it's a scaled item. And because many practices that were beginning their journey with quality improvement might have been focusing on things like team building or building blocks, and these take those into consideration, we also use that as a measure that facilitators could potentially improve to use as an outcome measure here. So if facilitators improved one of these 4 measures in at least 75% of their practices, they worked with 4 or more practices, they were considered more effective facilitators. If they improved these measures in less than 50% of their practices, they were considered less effective facilitators. The facilitators that improved these measures in 50 to 75% of their practices were not included in our study. So we were able to select the most effective facilitators and compare them to our least effective facilitators quantitatively. What I think makes our methods unique is that we were then able to, after we selected these facilitators and were blinded to which of the facilitators were more or less effective, we were able to look at some facilitator interviews, field observations, and analysis that we did with some of these facilitators, and in some cases, even interviews with practice members to see what it was that those facilitators described, or in some cases, we saw those facilitators do in practice. These interviews were done prior to us looking at the quantitative data, and therefore were descriptors that the facilitator used about their work, but we were unaware at the time whether the facilitator was a more effective or less effective facilitator. We did not have interviews for every single facilitator because our sample was very large, but the facilitators that we had interviews for were selected throughout the region on a purposeful and varied interview scale. And so we had interviews for many of the facilitators. You can see the results of our study here in terms of the number of facilitators and the number of practices per region. So each co-op is one of those 7 regions that I displayed earlier. So here are the number of practices participating and the number of practices having an external facilitator. There were a few, really primarily one cooperative that had a few facilitators that were internal to the organization, like a health system. And because those facilitators were so different and operated so differently, we excluded them for the purpose of the analysis. And you can see here the 158 facilitators in the study, although some of them did not have enough practices, and some of them were excluded due to the facilitators being internal to the network. So you can see the number of facilitators that had greater than or equal to 4 practices. 33 of them were considered more effective, 30 of them were considered less effective, and we were able to get interviews from both of these groups and talk to both of these facilitators, facilitators in both of these groups about their strategies and what they did. The first takeaway here is that practices who worked with a more effective facilitator, so if you were receiving facilitation from one of these facilitators in this more effective group, the way we defined it, you had a 3.6% greater change in your mean percentage of patients meeting this composite measure we created, which is putting aspirin, blood pressure, and smoking together, compared with practices working with a less effective facilitator. So these facilitators were more likely to make greater changes in a composite measure, which is the way we combined the 3 A, B, and S measures, leaving the CPCQ, the sort of adaptive reserve measure, out. The other thing that is to note on this slide is that the effective facilitators and the less effective facilitators are represented by virtually all of the cooperatives. You can see that there are some cooperatives that have more effective facilitators and some cooperatives that have less effective and more less effective facilitators, but that all of the cooperatives were able to contribute meaningfully to this group, all of them but one. And we'll talk a little bit about why not that one, but the more important thing is that all of these cooperatives had a slightly different approach to facilitation. Some of them focused more on PDSA, Plan, Do, Study, Act cycle. Some of them focused more on a particular aspect of improving care. Some of them focused more on one measure than another. Some of them focused more on sort of a philosophy of change. Some of them focused on more on doing things for the practice instead of teaching the practice to do things. They all had different philosophies, all of which are found common in facilitation, and all of which are discussed in the literature, and all of them were able to contribute, other than one, facilitators to this more effective group. So it's really not what the facilitation philosophy was or doing PDSAs that's making them more effective facilitators. We knew that philosophically these cooperatives were different. So there really is something else differentiating these facilitators. Through interviews, we were able to determine what those things were. So we looked at the interviews for the more effective and less effective facilitators. At the time, we were unaware which was which, and we were able to find several important themes that we feel really rose across our interviews. And we looked at these interviews very in depth for a variety of characteristics. And we felt like we had very much reached saturation, even though the data was collected a priori to the study question. One of the biggest differentiating factors I will lead with, which is this idea of cultivating motivation, tailoring, and addressing resistance. And the biggest differentiating factor was, we found, addressing resistance, how facilitators worked with practices who were hesitant to make a change. Facilitators who addressed resistance head on, either through small tests of change or through motivational interviewing, working with the practice, were more successful and were more likely to be in the more effective. This trait was more likely to be in the more effective group than the less effective group. On the left-hand side, you can see a quote from a facilitator that was in the more effective group, saying that you really have to understand personal dynamics, why you're doing this, what you're helping, finding something that's meaningful to them. So really tailoring this experience, being flexible about what you're working on, what the practice is working on, is really one of the key things that this facilitator found. On the other side is for a facilitator in the less effective group, and they describe the experience on their end, really thinking about their role as an educator and educating, what does the blood pressure metric mean? What can I teach this particular practice, and having this knowledge transfer relationship with the practice. And a lot of the facilitators in this group, the less effective group, would talk about not wanting to be in the practice's way, not wanting to push the practice too much, not wanting to make the practice uncomfortable, not wanting to have the practice feel like they were a burden, and really were nervous about that, and really wanted to impart education on the practice. The more effective facilitators talked more about making sure when there was resistance that they discussed it, they could address it, and that they could come up with a plan for what the perceived barrier was. It might have been a very small plan or a very small change, where they were, instead of talking about making a big change around a whole team, figuring out how one person could be involved, or how they could outreach to 5 patients over a week period. Very small things were often suggested as a way to address the resistance of a task that a practice did not want to participate in. And obviously, most of these practices were already opted in to research. And so that is an important thing to consider in all of these types of research studies. But making sure that the facilitator had the skills to address this resistance, I think, is something that is important for facilitation organizations, and our work really demonstrates the importance of this. The next thing that we saw consistently was that facilitators in the more effective group were more likely to describe the importance of helping practices to think critically, and saw their role as also providing accountability. And so practices thinking critically, getting them to have these critical thinking skills, sometimes aligned with some of the philosophies that cooperatives had, but facilitators, even in those cooperatives that didn't have this type of, don't do work for the practice, but teach a man to fish versus fish for the man sort of philosophy, even practices that or cooperatives that didn't have that had facilitators in those organizations that had the skill, trait, interest, or knowledge to get practices to think critically. So they saw their roles as guiding the practice and getting them to function on their own, to stimulate thinking, to build capacity, not just to be successful in the current study, but to address future changes. And then also had a project management type of mindset where they felt that they were there to agenda set, track reminders, track progress, ask people from meeting to meeting how they were doing, what the barriers were, how they could change the plan, how they could address things, and really saw that as part of their role. In our less effective group, we heard facilitators talk a lot more about doing things for the practice and trying to help them, or in some cases, be another set of hands. And while those facilitators were certainly well-meaning, and some of those practices were able to improve their measures for the study, when a different measure or something slightly different would arise, or when they would go to make a similar change, but ever so slightly differently, the practice often didn't have the skills. They weren't taught that, or when the facilitator wasn't present in between meetings, the practice would report that they were struggling and they loved the facilitator being there and the facilitator was very valuable, but then had some challenges between. So helping practices to think critically was one of those things that was a differentiator between our more effective and less effective facilitators in this study. The last thing that we noticed that was differentiated was that when we looked at the transcripts of the facilitators that we interviewed, after we unblinded ourselves and learned which were more effective and less effective, the ones that were able to really describe their role and say what they did, what their philosophy was, how they approached the practice, what they did when a resistance was met with. They were able to recognize nuances, detailed changes, and really were a very good descriptor of their own work, were actually the facilitators that were all in the more effective group. And so this may be important when we think about recruiting or hiring facilitators. If you're a practice member, asking what your facilitator's philosophy is, being able to have your facilitator share how they approach their work, what changes they're looking to make, and really making sure you understand what it is that they're talking about is really important. And it may be a differentiating factor for practice members to decide whether they want to work with a facilitator or whether that facilitator is a particularly good fit for them, or whether the study is a particularly good fit for them. Because really we found that our more effective facilitators were by and large able to do this very effectively. They're able to describe their work. And so I think with that, Anne will be able to talk a little bit about OCHIN's philosophy and the way that they support their facilitators and what they're looking for in research studies, and then hand it back over to me to finish up. Anne.
Lovely. Thank you, Shannon. First of all, thank you for managing the slide deck. I really appreciate that. And I really want to express sincere appreciation to you for sharing these study results, results that I am very enthusiastic about, because as you've described, it really is so important to understand the factors associated with effective facilitation, certainly so that it is scalable at the impact we're looking for. So this data from Escalades, I think, really speaks volumes to what qualities and needed supports to expect for effective facilitation. And I'm really happy to be able to share a little more about what this looks like in context here at OCHIN. So next slide, please. So as William kindly introduced me earlier, I am the manager of the practice transformation team at OCHIN, which provides practice facilitation support to our health center care teams. OCHIN is a nationwide nonprofit organization supporting clinics in the majority of states across the US. This means OCHIN practice coaches, our practice facilitators, don't have the geographic specialization common to other organizations, but rather we specialize in being generalists in both the transformation topics and the range of demographic qualities of health centers that we support. We accomplish this by partnering with researchers and subject matter experts who support a variety of technical areas at OCHIN in service to the nearly 200 health centers in our collaborative. Practice coaches work closely with informaticists, clinical program specialists, EPIC trainers, and really many other technical experts to provide transformation support to our care teams. Next slide. So the coaching approach at OCHIN emphasizes adaptive support. This is often referred to as soft skills. This is key to building the capacity and capability of care teams so they can succeed at delivering the patient care they want to deliver. And this idea comes from implementation science literature and really is an empowering approach to help care teams meet their goals, comparable to what you will see in other organizations. Adaptive support looks like support for identifying issues and needs and clarifying roles, that critical thinking that Shannon referred to, fostering motivation and commitment to the change process, and helping to create space and accountability for collaborative planning and decision-making. And these are all really key pragmatic areas for facilitation. How OCHIN is unique in this regard is that we provide tailored support almost exclusively in the virtual space. So we prioritize an empathic approach to support trust building. So alongside that pragmatic approach, empathic support is really essential to build rapport and trust that we know may spontaneously develop when meeting in person. Coaches prioritize compassion and empathy, utilizing training and motivational interviewing to help clinicians really feel seen and heard. And there is a little animation here to highlight an essential aspect of transformation support at OCHIN, which is coordination with technical subject matter experts. By partnering with colleagues and across various teams, we can really better ensure that we're providing the up-to-date guidance that our members need and are supporting their use of data for decision-making so that we can really deliver on providing that compassionate support needed for sustainable transformation. Next slide. So there is a lot that practice coaches do in order to support the change process. Practice facilitation involves a structured and complex adaptive systems approach in the techniques and tools that we use. Often it's really hard to explain the coach role. I know that it's sometimes really hard even for me, and I've done it for a while. Hard to explain how it functions because it is such a wide compilation of skills and inputs that create hopefully a very polished and seamless experience for the health centers we support. And this really is all the more reason why a large study like Escalates was so important to identify what really makes the role an important function for supporting implementation of change in primary care. So one key approach that we see as essential, particularly given that change can add burden on clinicians, at least in the interim leading to improvements, is to provide focused support for champions. Identifying and supporting champions is one of the first things that we do when we're working with care teams because champions help direct the change process locally. And the more complex the transformation, the more crucial this step of champion development and support becomes, because even if we were there in person, we would never be present at the elbow in the way that members of the care team or leadership staff simply are. Another key approach for sustainable and equitable transformation is supporting those parallel goals of the quintuple aim, built on that original triple aim for the healthcare improvement model that highlight the importance of care team well-being and advancing health equity. These aims are key priorities at OCHIN because our health centers serve some of the most underserved patient communities in the US. And from both national data and data that we track in-house, we are keenly aware of the many drivers of burden that impact care team well-being. So in our work with health centers, practice coaches focus on addressing clinician burden and wellness. And concurrently, we work to employ facilitation as a practice for equity that can help keep issues of health equity at the forefront of the work we do with care teams. And also related to the quintuple aim are those primary care building blocks. These structure how practice coaches support care teams to share the care in a whole system, person-centered delivery approach to really better deliver on the promise of patient-centered care. Next slide. So what practice coaches do is provide facilitation for care teams to implement and sustain specific interventions. So for example, screening and referral workflows for social drivers of health. Facilitation focuses on care teams learning to adapt and implement tools and processes that improve how they deliver care. This means a primary tool of coaching intervention is structured conversation. Coaches help teams engage in dialogue to explore the complex change they're addressing, review learning content and evidence-based guidance, and help them make a plan for action. We also, of course, use concrete tools like journey maps to gain qualitative insight into care processes. And we know care processes involve many layers of facilitators and barriers for both individual and teamwork. So importantly, a journey map really helps keep us grounded in compassion for the people doing the work. We also use workflow inventorying to capture inputs and outputs of a workflow and support planning for where change or enhancement is needed. And this is especially important for level setting around distribution of tasks and responsibility. And of course, we do action planning. This is a key part of change management, particularly because it helps with shared understanding of where improvement is needed and how to get there. Next slide. So this range of work is possible by setting up processes to support quality and accountability. And coaching work starts long before we begin engaging with our health centers. So these processes include developing an MOU and a protocol for coaching intervention, identifying and coordinating with subject matter experts who will support the intervention, and creating a communication and data support plan. So these are developed by coaches in collaboration with the project manager, and or if it's a research project, also the investigator, to outline expectations both with OCHIN team members and the clinic care teams we're supporting, and ensure continuity of the facilitated intervention. And progress of the intervention is monitored through development and deployment of pre-facilitation, and the slide should also say post-facilitation assessments to the health centers, and documenting the coaching support in structured field notes. And depending on the project, maybe also an intervention tracker tailored to monitor engagement of the clinic and progress. This information really critically informs how the coach tailors their work to support care team needs. But it is also key to the briefing and debriefing support needed for effective facilitation. And that support for the coaching practice takes the form of coaches sharing out their work with fellow facilitators and project team members, as well as with me as their manager, to really thoughtfully plan their engagement with care teams. So this includes actively reflecting on their work to understand barriers and facilitators of progress, and articulating what they plan to do in response, really in particular to support and motivate teams to keep working on their goals, just as Shannon was noting, that resistance management piece. So having a strong reflective skill set is an essential part of the job to adequately review how their work is going and identify where change may be needed. And this informal process is complemented by observation by peers to provide feedback on competencies like communication and accountability practices, as well as applied learning of our in-house training curriculum, where coaches are expected to hold core competencies and then build additional strengths through their engagement with our health centers. And then also autonomy, perhaps paradoxically, is also an important part of the oversight process, and that coaches really need conditions that empower them to explore how to best meet health centers where they're at. So this really requires skills in both creativity and tenacity. And finally, an important part of monitoring quality and supporting accountability is the expectation for coaches to report out routinely about learnings they're gaining from their work with clinics, which really helps to identify learnings that may be able to help other health centers. Next slide. So this animation, we think, really sums up how we like to picture facilitation support, where coaches help with sense-making, teamwork, and facilitative leadership, those qualities of adaptive reserve that help individual clinicians and really the care team as a whole manage and adapt to change. Escalate data, I think, really tells us that more effective facilitators can make a significant impact for care teams' ability to improve patient outcomes, which is exactly what we want to hear. And that patient outcomes really can be improved with improvements to how care teams deliver care. What I would also assert is that there are benefits of facilitated intervention from having that coach helping those care teams so they have that improved experience of the transformation process. Changes to care processes can all too easily create significant disruption, uncertainty, and frustration. And so practice coaches really work very deliberately to avoid or minimize these concerns so that staff can feel supported and hopefully really be able to celebrate their wins. Next slide. Okay, so before I pass back to Shannon, I do want to share a snapshot of team members among the much wider OCHIN team that delivers transformation support to our health centers. Our colleagues under the clinical operations umbrella are key partners in our work, and I have fantastic appreciation for collaborating with them every day. And really, I'm thankful for getting to collaborate with so many colleagues across OCHIN and now externally. Really, thank you so much, Shannon, for the opportunity to share in this conversation about practice facilitation and help spread some enthusiasm for these great findings.
Thank you, Anne. It's really nice to hear so much about a particular approach and philosophy, and it's been so nice to partner with you because it really, although OCHIN was not one of the organizations that participated in Escalades, I think so many of the things that we have found that make more effective facilitators are in the structure that you all provide. And one of the things, two things I wanted to note, which is that there was one element of not differentiation that we put in our paper, which a lot of people think is going to make a difference. And it is having facilitators be very technically trained, like HIT savvy. And we found that although it is important for facilitators to be HIT savvy, it was not a meaningful differentiator between our more effective and less effective facilitators. And that's in large part because so many of these other things are so much more important, really. And one of the other things was, although it's important for facilitators to have a strong background or experience in facilitation and coaching, what their background or experience was also was not a meaningful differentiator among the more effective and less effective group. But in the other study that I said I would loop back to, one of the other things that was important was having the support network and having a structure and having monitoring, which is exactly what you just described that OCHIN has, that was important. And the cooperative that had 0 more effective facilitators was much newer at doing these types of things and had not only a study design that was very short, but also didn't have as many of these other things in place. So although these cooperatives had different approaches, all of them basically were able to contribute to this group. But this one place, Cooperative 5, the study timeline was only 3 months of facilitation effectively, compared to 1 year to 15 months in other places. And even if you are a really, really effective coach, which we may have had in that cooperative, the study timeline actually trumped the ability for the facilitator to be effective. So I think that's a meaningful thing for folks to think at too, to your point, Anne, that transformation is hard work and it can take a long time. When you're looking at a short time horizon, it can be a challenge. Those facilitators may or may not have had the skills to make practice transformation changes happen, but they were not given the timeline to do it. And so there are other things that go into making effective facilitators. But this last bullet point here, that the cooperatives that were able to assess learning needs and really intentionally and consistently provide the support through peer support, through learning libraries, through resources, through having a manager, through having other people they could talk to solve problems, also were the facilitators that had those higher numbers of the more effective facilitators, because they were able to minimize almost the effect of the facilitator background and experience, right? So if you have an organization that is really stellar at doing this work, that's supporting facilitators well, that has peer support, that has someone you can go to when you have a problem, having meetings, having shared sessions, that organizational support may be sort of, a rising tide lifts all boats, like lifting some of those less skilled facilitators up, and an organization that doesn't have those maybe not doing as much justice to those facilitators. And so I think one of the reasons that the effect of the facilitator background and experience was not a differentiating factor that we expect it to be is because of this organizational support. And it's why it's so critical for organizations like OCHIN to make sure they're providing that support at such a high level, because it helps even the most skilled facilitator, but it also helps your newer or less skilled facilitators become these more effective facilitators that can make practice changes, and that can make practices feel supported, and that practices can feel like they're really getting something out of these interventions and seeing the changes, not only in the study components that they're participating in, but over the long haul. So again, this is one of the quotes just to show how important organizational support was. And it's what I think OCHIN is doing a nice job of providing, is that this particular facilitator feels like without having the support of the other facilitators, and her organization was bringing these facilitators together for these regular meetings and check-ins and filling out the intervention tracking. Without this library, without being able to go and do this, she just didn't feel like her job would be as she would be able to do her job as well. There's a whole list of resources that she can go to and she can use, and this structured system was really important in her mind. And so that was one of the things that we also saw as not differentiating among facilitators specifically, but that organizations that provided that were able to have more facilitators who were more effective. And then monitoring quality, just like Anne just described. We saw this in our first study where we were talking about the support of these large scale organizations, but it connected back to looking at our effective facilitator study, where monitoring quality really was important, both for consistency across the intervention to make sure that practices received similar amounts of facilitation and a good facilitation quality, but also was really important internally to the organization to make sure that they were training, teaching their facilitators, and that quality issues were seen as a way where they could teach their facilitators and provide them with those skills and do needs assessments for the facilitator organization and see what they could be doing for their facilitators. So this particular quote was from a facilitator lead saying they're reading these field notes, they're flagging issues, and then they're following up with the facilitator organization. And then, they're using these as teaching opportunities so that the facilitators in the future can better help the practices. And facilitators who mentioned these supports and were able to describe these, again, describe their job, describe what they do, were more effective facilitators. So we see the support systems that we saw in our first paper, the ones that were the most important sort of to take facilitation to scale, tie into what makes an effective facilitator and an effective, one might say, facilitator organization, like we see at OCHIN. So putting it all together, facilitation, as Anne says, the quality varies, and the softer skills that we identified here, we think are some of the ones that really do differentiate these more effective from less effective facilitators: the cultivating motivation, the tailoring, the addressing resistance, the helping practices to think critically, that accountability piece. And these skills can really be developed regardless of facilitators' previous experience, whether that's HIT previous experience or whether that's clinical previous experience. These skills aren't really specific to a particular past job or background. And although HIT training, as we said, was important, it wasn't one of those differentiators. And so we need to be thinking about these soft skills as part of the art of facilitation, and how facilitation changes get made gets focused on these softer skills, which sometimes are harder to teach, harder to measure, and harder to look at, which is why there were so few studies that were able to look at this. And then although this facilitation philosophy and study design could steer facilitation work, all these, as we've mentioned, these different cooperatives had some of these effective facilitators, although some of the organizations were more able to get more of their facilitators to fall into that more effective group, probably because of some of the support strategies that they had in place. And thinking about, managers and thinking about yourself maybe as a practice member, and thinking about whether you want to participate in a facilitation project or coaching project. These are synonyms. Managers, practices may be able to learn about efficacy and about the fit of facilitation by listening to a facilitator or a facilitator organization describe their work, describe their process, talk about their philosophy, much as we were able to see today. So providing these infrastructure elements and hearing about infrastructure facilitation may not seem particularly sexy, but it really is important to ensure that the facilitators that practices receive are really, in this more effective group and are able to have practices meet their goals, make the transformations that they were hoping to. So all of these things are really important to support our facilitators, and hopefully as facilitators continue to learn about what makes we all as a field continue to learn about what makes facilitation more effective, we're able to impart these skills, knowledge in facilitator organizations and specific facilitators to have more effective facilitators in the future. So I just really appreciate being asked to do this talk with Anne. It was such a lovely partnership. And I acknowledge the Escalade's team. This study ended a few years ago, but it was a really wonderful big team. And we have more information and other studies that came out of this work on our website, escalades.org.
All right. Thank you for that fantastic presentation. If people have questions for Anne and Shannon, please type them into the chat or Q&A box. We have one right here from me, which is, this may feel kind of like a broad question, but it was coming up in the presentation, is what kinds of backgrounds do you see in individuals who are interested in pursuing the path of practice facilitation? And I guess kind of as a follow-up to that, how does one get into working as a practice facilitator?
In the Escalade study, there were, I would say, two clear paths facilitators came into. One is a clinical background. So they were working in a practice, sometimes as an MA, some were nurses, and were interested. Often they would have a facilitator come and work with their practice and then be like, oh, actually, I want to do that. I want to help practices make changes. I love working in my practice, but I actually think my skill set might be better used. And we'd have facilitators talk about, how some of the softer skills that are actually really important in facilitation, they felt like were being underutilized in their role as an MA or their role as a nurse, and they felt that they could better utilize them as a practice facilitator. And so that is one background area. And there were some hypotheses in the literature that people who had clinical backgrounds might be more effective facilitators because they were so knowledgeable about the way clinical practices worked and the workflows and systems. And we didn't find that to be true in our study. The second sort of path is HIT expertise, expertise with EHRs, EMRs, and sometimes working for some of those organizations. Again, very helpful skill to have, because a lot of the changes that facilitators help practices make need to be documented, and they need to be documented in these EHRs or EMRs. But only being able to change something in the EHR or EMR is not really what we think of as a full clinic transformation. And therefore, it did not differentiate our more and less effective facilitators to only have those skills at the, risk of not having some of those other soft skills. And so some of the HIT facilitators in Escalades would be with their peers who are not HIT and say, oh, these are some skills I don't have. I might not have these clinical skills, but you could go to a clinician and figure them out. But I need these training. I need training in these softer skills because my background is so technical. And I'm finding that is my shorter area. So those were the two main groups we have had. But Anne, I'm interested to hear if you have other big backgrounds of folks of how they get into facilitation.
Well, I agree with everything you say. I would just sort of pick up on one thing you noted about maybe someone working in the clinic feeling really excited about what they see in this work and wanting to do it. So I would name that it's really an intrinsic passion that coaches have, that I think if you're going to be effective, it's because you're really motivated. You just gravitate towards the role and really feel compelled to help people with change. And then related to that, less so what particular degree program you have, that's not really important, but I think just having professional background and maybe just kind of viscerally having experience the kind of discomfort or pain that comes with going through change, maybe community, particularly with a group, and just that learning, experiential learning, makes you more effective as a facilitator and likely more interested in doing the work.
Awesome. Thank you. And if there are any questions, we have a couple minutes left. Please feel free to chat in with the Q&A or text box. We have another question here. This is more of a boots on the ground kind of question. Are there any unique challenges between providing practice facilitation support in rural or urban settings?
Yeah, we found this to be true. So because Escalade's study sample was so large, because we had almost 1,500 practices across the US, some of them were in quite remote locations. We even had some in like frontier locations in New Mexico. And getting facilitators in Escalades, most of the facilitation was physical. And so getting facilitators to those locations is hard. We had a lot of facilitators describe their days and having a lot of windshield time, meaning that they went to these communities and spent a lot of time driving. Facilitators that were from the communities that they facilitated in described it being easier to facilitate in those communities. So in New Mexico, for example, where there were a lot of tribal locations, some of the facilitators were from the surrounding areas or from tribal areas, and they felt like they were able to make better connections, understand the health of those populations better than some of their peers who might have been driving from the university in Santa Fe or whatever. So I think that's one of the things that can be different. We did not find that the geography of the practice nor the geography background of the facilitator made them more or less effective, but that is a thing to think about. And then on the other side, in urban areas, we had practices in New York City, and I observed in New Mexico and in New York City our facilitators, or the facilitators in Escalades. And some of those practices you think of in New York City, because they're very urban, had people still coming from very far away through like many modes of travel, like many subways and whatever. You don't think of it being far away, but some of those clinics serve very specific populations. So they might be a clinic that serves Chinese Americans, and most of the people are speaking Chinese, and the clinician is speaking Chinese, and they have certain beliefs or certain things like that. And having, again, a facilitator who understood the cultural beliefs of the clinician or the patient population could also be important. And also many of those practices are single doc practices, which there are not a ton left of. And doing transformation work as a single doc practice it has a pro and a con. The pro is that the clinical champion is typically the doctor, as these are often, one MA, one doctor sort of offices. The downside is these physicians do not have a lot of extra time to engage in this kind of work. Every time they are doing their transformation work with a facilitator, that is an hour they cannot bill not seeing a patient, and that's a real challenge. So I'd say those are the things that come to me offhand, but OCHIN has a really wide network, and I'd love to hear if you had any sort of different thoughts on that.
Yeah, I love all the points that you made. Fully agree. I would say we get the benefit of, we have account managers who are familiar with the members that we'll be engaging with, so we can lean on them to get some of that important familiarity that you're mentioning, that unless we were there locally, we wouldn't know.
All right, I've got one more question. We're right in the last few minutes. With all these great learnings presented here today, what do each of you think is the big takeaway you'd like us to remember, to reflect on regarding practice facilitation?
I think the biggest thing around practice facilitation is that there are these soft skills that differentiate your more and your less effective facilitators, and that practices who decide to engage in these should be looking for those and should be thinking about what their goals are and how their facilitator can help align them using these soft skills, like thinking critically and like managing resistance, and that facilitators in this role should be thinking about those as their most important skill sets that they can bring to practices.
I would just double down on the fact that we use the term adaptive skills here at OCHIN, because I think soft skills is a bit of a misnomer that I think you've even named, Shannon, that it's some of the hardest skills that you employ, but we call it soft. And so what I look for really, and with would encourage folks, if they're interested in this field, is to consider, like, what do you do to really kind of expand your horizons perspective wise, so that you have that kind of adaptive skill set around making sense and helping with critical thinking. So maybe you've learned some foreign languages or lived in foreign places, or just, had different exposures, so that that makes you more facile as a person engaging with folks in doing change, because it is such a dynamic process. So I'd say the takeaway is really that adaptive skill set.
I always put soft skills in quotes when I do these
Perfect.
presentations, and I need to stop and just replace the term, which I feel like even in literature, like we publish stuff that says like soft skills. So you know what? Here's to my resolution of adaptive skills in my writing.
I love it.
All right. Well, thank you, Dr. Sweeney, and thank you, Ms. Romer, for that fantastic presentation. And thank you to everyone who attended today's session. If you're interested in learning more about Escalates, please visit escalates.org. That's ESCALATES.org. And follow them on Twitter at @escalatesorg. You can find OCHIN on Twitter at OCHIN Inc. and over on LinkedIn. In addition, head over to OCHIN.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And don't forget to visit our OCHIN YouTube channel to catch up on those past Grand Rounds presentations. And stay tuned for next month's OCHIN Grand Rounds, where on March 16th from 12 to 1 p.m. Pacific time, we welcome Doctors Carolyn Berry and Maggie Paul of New York University, who will be presenting on measurement development to accelerate the translation of evidence-based clinical guidelines into practice. Invitations to this presentation will be sent 2 weeks prior to the event, but if you are not on our mailing list and are interested in attending this or any future event, please email me at grandrounds@ochin.org. That's grandrounds, all one word, grandrounds@ochin.org. So from all of us at OCHIN and Dr. Sweeney and Ms. Romer, to all of you, have a wonderful rest of your day and stay healthy out there.